Okay guys, welcome to the first video of the GI series, and GI bleeding is something that can be like so torrential that it can cause death in a couple of minutes, or it could go undetected for weeks altogether. I can discuss a case of a patient who was having melena for a week. He was neglecting it, and then one fine day he had was a torrential hematochezia. That's a lower GI bleeding with crashing of blood pressure. The question said, what is the first investigation to be done in this case? And the answer is not colonoscopy, though it specifically mentioned acute lower J bleeding that is occurring in a patient with hemodynamic compromise. The first investigation is not colonoscopy, it is upper J endoscopy. See, what would have happened in this patient is that probably he was having a duodenal ulcer, that too probably a giant duodenal ulcer, and there would have been an erosion of the gastroduodenal artery, which would have resulted in a torrential lower J bleeding. See, these words like upper J or lower J bleeding, they're basically causing unnecessary confusion, because every time we read the word lower GI bleeding, the thought process is okay, we should be scanning the lower part of the GI using a colonoscope. But the point to be understood is that agreed the blood is coming out from the bottom, but where is the source present? The source was present in the duodenum. So the first take home message in this video is, in any question that mentions or in practice there's an acute lower GI bleeding with a hemodynamic compromise described, he says the word hemodynamic instability, crushing of a patient, the answer should be given as upper J endoscopy as the initial investigation to be done. And now I'll mention regarding a couple of classification and scores which are again asked in the exam. And the first one on the agenda is Glasgow Blatchford classification. Well, the questions was a one-liner. This would have been taught in surgery also, like why do we use this classification? So it is to predict the need for hospitalization. I can give a parallel example here. Like, you are aware that in pneumonia we calculate a curve 65 score to decide the need for hospitalization. Similarly, in a case of GI bleeding, whether it is upper or lower GI, to decide whether the person needs a hospitalization or not, I'm going to use a Glasgow Blatchford score classification. The parameters of this will also be discussed, but at the moment the message is value more than 2 is where the hospitalization needs to be done. Then is AIMS 65 score. The full form of this AIMS 65 will also be discussed and has been asked in the exam. But at the moment, like after the patient has been hospitalized, what I will also do is do a triage. And what I mean by triage is that I'll be calculating the chances of mortality. So one, like this score is going to predict chances of mortality, and higher is the score, that would also mean that I need to send this patient to intensive care unit. And this also tells me that aggressive interventions need to be done for this patient. I mean, higher AIMS 65 score means that there is a need for endoscopic treatment of the patient. Usually the word written would be like endoscopic therapy. Now, what do we do in endoscopic therapy? I'll be able to explain to you in the next couple of slides. But at the moment, I said, first I'm admitting, then I'm deciding like, okay, should I keep him here only? Should I keep him to send him to ICU? Do I need to go for an urgent endoscopic intervention? And now let's assume endoscopy is being done. And when endoscopy is done, then the view inside the camera will give a view where we'll be able to see some specific findings. Now, if he says the word visible vessel spurting blood, then I need to inject adrenaline into that source. We need to, after injecting adrenaline, maybe go ahead subsequently and deploy a hemostatic clip, or we might have to decide a thermal coagulation so that the bleeding can be stopped. So depending on the endoscopic findings, we will then decide what kind of intervention needs to be done. And for that, we have a classification that's called as Forrest. Forrest classification is to decide for the need of endoscopic therapy in a peptic ulcer disease patient. This classification is specifically for peptic ulcer disease bleeding patient, peptic ulcer disease contributing to development of hematemesis in an individual. So I'll repeat the 3 points once again. First is I'm deciding any patient with GI bleeding coming to me. It can be upper, it can be lower GI. Should I admit the patient or not? Once I've admitted, I am then deciding, okay, what are the chances of mortality? Do I need to go for endoscopy in the patient or not? And once I've done endoscopy, then the next thing is, based on endoscopy, what is the type of intervention that needs to be done? I mean, do I need to be aggressive enough to inject adrenaline? Do I need to deploy a hemostatic clip or not? Like in Mallory-Weiss syndrome, we don't need to go for any aggressive intervention. It is self-limiting. But in a peptic ulcer disease bleeding, there is like a definitive need of aggressive intervention to be done. So these are like 3 classification scores, the names of which that I mentioned at the moment before you. And the flow of this video would be, I'll talk about conventional upper GI, lower GI bleeding, and small intestinal sources of GI bleeding as well. The anatomical landmark that we use for upper GI and lower GI bleeding is ligament of Treitz. I mean, if the bleeding is occurring proximal to the ligament of Treitz, we will be calling it upper GI. If it is occurring distal to the ligament of Treitz, we'll be calling it lower GI bleeding. And if he says like, what is the location of this ligament of Treitz, then the ligament of Treitz location would be at the duodenojejunal flexure. At this moment, I also want to bring to your attention that if I'm using a conventional upper J endoscope, I will not be able to navigate beyond the ligament of Treitz. So if I want to scan the area distal to the ligament of Treitz, I will have to either go in for deploying a wireless capsule endoscopy, or instead of wireless capsule endoscopy, I can be using MR enterography, or I can use a pediatric colonoscope as well. I repeat my statement, till this particular area, my routine upper G endoscope will reach. But if I want to scan the area distal to it, then the options available before me are like wireless capsule endoscopy. Like if a person is having Crohn's disease, then Crohn's can be involving the ileum, it can be involving the jejunum. So scan that, we can do a wireless capsule endoscopy. If I don't have a facility, I can do a MR enterography of the patient, or another option can be that we can do a deep enteroscopy as well. So I'll be speaking about those, I would say, available options before us and which ones to select as we progress in our discussion. And for patients who are presenting to us with upper GI bleeding, it would be vomiting of blood. So hematemesis, the meaning of that would be that it would be bright red vomitus. But this would be usually the initial episode. Subsequently, the second or third episode of vomiting that will occur will not be red, it will be brownish in color. You see, suppose somebody is having portal hypertension due to alcoholic cirrhosis, and he's having esophageal varices that have ruptured. So when this guy will puke blood, that's understandable, but some blood due to gravity will go in the stomach also. And when the blood will go down in the stomach, there is acid there. So it will degrade this hemoglobin to produce acid hematin. And this acid hematin is like brownish in color. So therefore, the second, the third episode of vomitus that would be occurring in our case of bleeding esophageal varices, he will not say bright red vomitus. He will say the word coffee grounds vomitus. What he means by the word coffee grounds vomitus is that brownish appearance of the vomitus. And that's because of the degradation of hemoglobin producing acid hematin. Then I've already explained to you that if a person with upper J bleeding, like a giant duodenal ulcer, is having hematochezia, which is causing hemodynamic compromise. See, if I just say the word hematochezia, then hematochezia can be seen in piles also. For piles, I don't need to go for such aggressive intervention. Piles can be identified even by something as simple as a proctoscopy also. But if I say hematochezia with hypotension and there's even a drop of hemoglobin of this patient, though the drop of hemoglobin will not occur immediately, you will notice that even if somebody is having a life-threatening bleed, the drop of hemoglobin might take as much as like 40 to 72 hours. But in any patient of hematochezia with hemodynamic compromise or a crashing blood pressure, we are gonna classify it as like probable cause being upper GI, and therefore upper GI endoscopy needs to be done in the presentations that are currently mentioned on the lower part of the slide. As I mentioned, some patients could be having coffee grounds vomitus, though the initial vomitus can be bright red in color. Now, Glasgow Blatchford score I've already spoken about is used to assess the need for hospitalization in upper GI bleeding. Any value more than 2 means that patient needs to be admitted. If the value is more than 7, then endoscopic care needs to be done, ICU care needs to be done. And because the person would be having bleeding, there's gonna be like volume depletion, so BUN can be elevated. The value of hemoglobin may be taking time to fall, but if somebody is having like bleeding, ongoing bleed initially, and now it's become torrential, so hemoglobin would have fallen in these patients. Because of the torrential bleeding, the systolic blood pressure will begin to fall, and there would be increase in the pulse rate or heart rate. And then comorbidities need to be considered. Comorbidities would be like melena, syncope occurring because there would be like a cerebral hypoperfusion. Then if he's having liver disease, the chances of bleeding will be more because liver is the site of clotting factor production. If somebody is having heart failure, already is a known case of atherosclerotic cardiovascular disease, and now is having a GI bleed. So then the chances of these patients, the heart of these patients is already damaged. So the heart will not be able to take that stress. So the chances of mortality in this patient will then increase. And that is why I said I need to step up care. I need to admit him into intensive care unit. And any patient with more of these scores, higher the score, that increases the chances of more complications and a much more stormy hospital stay. Initial interventions to be done in any patient with vomiting of blood, because the person is having hemodynamic instability. So I need to attain a target blood pressure of at least 90/60. Like suppose he says that patient is having tachycardia, the blood pressure is 80/60 or even lesser than that, then my target will be to reach up to at least 90/60 by putting a wide bore cannula and giving fluid resuscitation. Blood grouping and cross matching will be done. We will arrange for blood, but we may not immediately give blood transfusion to the patient without fixing the problem. Because if I'm gonna give blood transfusion to this patient, blood will keep on, oozing up from the original site. Like if it's a peptic ulcer disease with the eroded gastroduodenal artery and the spurting of blood happening, then it's a waste of resources. I need to fix the source of bleed also, and then I can proceed with blood transfusion rather than just filling the blood in the body of the patient. Because on one hand, I'm sending blood in the body, second, it is getting lost. So he says that you can manage the patient to get a target BP of 90/60 on admission using fluid resuscitation. And because one of the leading causes of hematemesis is peptic ulcer disease, so we will also start PPI infusion in the patient. In these patients, after like 2 to 3 days, we can then step down to potassium competitive acid blockers. Potassium competitive acid blockers that we can use as like vonoprazan. So that's like a step down from PPI. Like we can step down from IV PPI to oral PPI, or we can step down from IV PPI to even oral vonoprazan for these patients. Now, before I plan an upper G endoscopy for any person, I also need to ensure that the motility part of the, or like the emptying part of the esophagus is done, and the emptying part of the stomach part is also done. Because after all, there's gonna be like a lot of blood present in this entire circuit. So if I can improve the motility and the emptying part of this part, then better visualization can be done. And that is why we can give a prokinetic agent. The agent that we usually give is like either metoclopramide, but the ACG guidelines recommend administration of erythromycin. That would be given intravenously. That is the pro-motility drug. The objective of this pro-motility drug is that it will send blood in a forward direction. So the visualization part, I mean, you have to find the cause, like why the blood is coming. So to visualize the source, that is why the prokinetic agent would be given to this patient 30 to 60 minutes before performing upper G endoscopy. Then, because a lot of patients can be having alcoholic cirrhosis and portal hypertension, and in alcoholic cirrhosis, there can be even presence of ascites. And if a person is having ascites, there is always an increased risk of development of spontaneous bacterial peritonitis. So another generic treatment that I've written at the moment, I mean, it depends on case to case basis. If it is PPI only, then it's only like, we can give erythromycin to the patient, and then subsequently endoscopy would be done. And then based on the finding that is in gastric ulcer, duodenal ulcer, specific interventions need to be done. But if it's a liver case with alcoholic cirrhosis, with ascites, and a possible risk of development of spontaneous bacterial peritonitis. Now, spontaneous bacterial peritonitis is discussed in the liver section. It basically means that there will be transmigration of bacteria from the bubble wall to the peritoneal fluid. And if I do a ascitic tap in spontaneous bacterial peritonitis, it will be showing neutrophils. Like neutrophils have no business to be present in ascitic fluid. If we are having neutrophils in the ascitic fluid, I need to give them ceftriaxone. I mean, because spontaneous bacterial peritonitis is usually caused by E. coli. But on the other hand, if an alcoholic cirrhosis patient is having portal hypertension, then for portal hypertension, there are two approaches of vasoactive drugs that can be used. One is octreotide that can be given in the form of an infusion, or we can be giving terlipressin. Like if I don't have an infusion pump in my hospital, then I can be using a terlipressin bolus in the patient as well. So I can say this is again more of a generic kind of a slide where I've said like what I'm gonna do initially in any patient coming with hematemesis. That is, first anticipate that this guy could be having peptic ulcer disease, because overall the most common cause of vomiting of blood is PUD, and most of the time it would either be duodenal ulcer or a gastric ulcer. Now, what are those upper G endoscopy findings that are given in the question that would prompt you for aggressive intervention? The words written in the question can be like visible vessel, or he may say active bleeding, or he may say the word adherent clot. In those circumstances, endoscopic therapy needs to be done. What I mean by the word endoscopic therapy is like if there's a visible vessel that is bleeding, we will first like to inject adrenaline so that we can reduce, because adrenaline will be having by adrenaline local administration, we will be able to have a vasoconstriction and reduce the amount of bleeding. Now, subsequently, step 2 after this would be, because adrenaline is a vasoconstriction, so the oozing part of the blood has become relatively lesser. But now, because it's a bleeding vessel, so once the effect of adrenaline will go away, it will start bleeding again. So we also need to deploy hemostatic clips here. The rationale behind the deployment of hemostatic clips is to fix that blood vessel, which is the source of bleeding. And along with this, additional strategy that we might be using is thermal coagulation. You see the duodenal wall is very thin, so there has to be a limited amount of coagulation that can be done using a thermal method. Because the duodenal wall is very thin, it can result in like extensive damage as well. We can have a perforation of the bowel as well. So these are like the steps. What I mean by the word endoscopic therapy is, first we inject adrenaline, then we deploy hemostatic clips, and if required, along with that, thermal coagulation would be required. And for these patients, once the bleeding part has been controlled, we'll anyway be giving PPI infusion. The objective would be to increase the intragastric pH of this patient. I mean, every time we are giving PPI, our objective is to attain intragastric pH of usually more than 6 in this patient. I mean, that is my target over the next couple of days, that I get a intragastric pH of at least 6 or more than 6. Initially, like first day patient was 6, so he'll be nil orally, but from subsequent day onwards, once the endoscopic procedure has been done, we can start the patient on clear fluids, and most patients would be discharged by the third or the fourth day. So I just wanted to bring to your attention that in any patient of peptic ulcer disease, the decision making of whether to go ahead with endoscopic therapy or not will be based on the findings that I mentioned here, like a visible vessel adherent clot, and this comes under what is called as forest grading. So forest grading or forest classification, I mean, the name is coming up once again, I'm writing the name once again, is to sensitize you to the fact that this helps you decide whether endoscopic therapy needs to be given or not. Because if he says himself in the question, spurting arterial bleeding, oozing, hemorrhage occurring, then we need to go for urgent priority endoscopic therapy. But suppose he says in the question, flat pigmented spot, clean base ulcer, if this is the terms that are written, then you can see that there is no need for endoscopic therapy in a patient. So forest grading is done to decide the need for endoscopic treatment in a patient, unlike in Glasgow Blatchford, which was need for hospitalization. When it comes to the next one, that is AIMS 65 score, then AIM 65 score, A stands for albumin, I stands for INR. Both of them have been taken into consideration, because not all patients who come to us are having PUD. Some can be having alcoholic cirrhosis, and then they could be portal hypertension. So in alcoholic cirrhosis, albumin will be less. Liver is the source of clotting factor, so therefore international normalized ratio will be elevated more than 1.5. Then because of the cerebral hypoperfusion, because if you lose blood from the body, there's cerebral hypoperfusion, so mental status will be checked. Then is checking out the systolic blood pressure, checking out the age of the patient more than 65. AIM 65 score basically helps me to predict the chances of mortality. So you can see that each one of these are doing a different job. Like forest, I'll repeat once again, is to decide what is the type of endoscopic intervention that would be being done, in a sense that are we going ahead with that adrenaline injection or not, are we going ahead with that hemostatic clip deployment or not. If he says flat pigmented spot, clean base ulcer, the answer is a no. But if it's like a oozing hemorrhage, then the answer is a yes. And along with this, like I spoke regarding the components of AIM 65 score, let's do a quick recap. 15 seconds, albumin, international normalized ratio, 2 components of the liver, then is mental status and systolic BP, which are interrelated to each other, and age of the patient. As far as the leading cause of upper GI bleeding is concerned, it is peptic ulcer disease, but not all cases would be that of PUD. He can also give you a case who's having erosive gastritis. Now, the reason for these erosive gastritis can be like curling ulcer that is seen, or Cushing ulcer, curling in burns, Cushing ulcer in cases of raised ICP, or I can say any patient who's on a ventilator. The stress on the body can cause excessive acid production and can cause development of erosive gastritis. That is why patients on ventilator regularly PPIs are given to these patients. Then the next thing to be taken into consideration is possibility of esophageal varices. So I'm also giving you a roadmap with respect to when patient comes with upper GI bleeding, that is mentioning of bright red vomitus or subsequently coffee grounds vomitus, then this is the thought process of mine. The next cause that I'm writing before you, Mallory-Weiss syndrome, this is non-life threatening. This is a submucosal tear, and therefore there is no threat to life with Mallory-Weiss, which is usually going to be associated with the word retching in a question, that is forceful vomiting is what patient is attempting. But like during this attempt of forceful vomiting, there could be a tear in the gastroesophageal junction, which could result in this bleeding. In Mallory-Weiss, the blood is not coming from esophagus, it is from the gastroesophageal junction. And then we'll also talk about a abnormal blood vessel in the submucosal area. Normally blood vessels are towards the serosal side, but here we are having a blood vessel on the submucosal side that is called as Dieulafoy's lesion. So PGEMD is like a mnemonic that helps us remember the causes of upper GI bleeding. And now we look at each one of them individually. Peptic ulcer disease, if he says what is the source of bleeding in the gastric ulcer, then it's gonna be left gastric artery. I mean, after all, it's an arterial bleed, so it can be fairly torrential and can cause hemodynamic instability in a couple of minutes. In a duodenal ulcer, the source of bleeding is called as gastroduodenal artery, and as I explained to you, if it's gonna be like a bleeding vessel documented on upper GI endoscopy, what we need to do is first inject adrenaline, then subsequently we'll take care of the problem using a hemostatic clip or a thermal coagulation or a combination of the two. But if it's gonna be like erosive gastritis would mean that the production of prostaglandins, you see, COX-1 inhibitors will interfere with the production of prostaglandins, and prostaglandins have a stomach mucosa protective role. So in erosive gastritis, the common thing is that the prostaglandin production is compromised, and that is why like there is erosions that are developing that can result in bleeding. One of the reasons for this can be painkiller abuse, then can be trauma, burns, that is curling ulcer, raised ICP, that is Cushing ulcer. Any patient on ventilator, any patient of ARDS, they can be having upper GI bleeding. That is why we give pantoprazole for these patients to prevent the chances of this catastrophic event. What you can see here is adherent clot, and two nasty ulcers can be seen in the duodenum of this patient. So it can be like more than one ulcer also. Traditionally, we get a single ulcer in the first part of duodenum, but duodenal ulcers are always a problem. The posterior duodenal ulcers are the ones which are more likely to bleed, and the anterior duodenal ulcers are the ones which are more likely to perforate. You would have read that in surgery also. Anterior duodenal ulcer, more chances of perforation, and the posterior duodenal ulcer will have higher chances of bleeding. Then we can have gastric ulcer. In fact, here I can also mention that the most common site for gastric ulcer, if he says like what is the most common location, then your answer would be the lesser curvature. You see, I'll not get into that Johnson classification that is discussed by the surgeon, but I can just make a passing remark to the fact that gastric ulcer, the most common site is the lesser curvature. And as far as the duodenal ulcer is concerned, the site of duodenal ulcer will mainly be D1, that is the first part of duodenum, that is duodenal cap. Then it was erosive gastritis. Then subsequently, the causes to be considered are like esophageal varices. You see, the cause of esophageal varices is portal hypertension. So the definition of portal hypertension is hepatic venous pressure gradient more than 5 millimeter. But bleeding will usually occur when the hepatic pressure gradient is more than 12 millimeters of mercury. And what is the source of bleeding? The source would be answered as left gastric vein. This left gastric vein is a direct branch of the portal vein, and along with that I've written azygos also, because after all, what is happening in these patients is development of portosystemic collaterals, and therefore like the simplest answer for me would have been that the source of bleeding in esophageal varices is from the portosystemic collaterals. But in the exam there was no mention of any portosystemic collaterals. He gave these names of random veins like left gastric, right gastric, and our first answer would be left gastric vein, where it meets with the azygos vein, because that's where the portosystemic system is meeting and there is development of collaterals. If he says what is the leading cause of portal hypertension in adult population, it is cirrhosis. Well, why are we having cirrhosis? Then there can be two reasons. It can be alcoholic or it can be non-alcoholic cirrhosis also, like it can be NASH, non-alcoholic steatotic hepatitis, that can progress to development of cirrhosis. Then if he says what is the leading cause of portal hypertension in children, then answer would be given as EHPVO, that is extrahepatic portal vein obstruction. Do remember that statement of mine, that if he says, I think this was FMG exam question, he mentioned regarding that this patient, though there was a risk factor given, that the child had umbilical catheterization done when he was a neonate. In any patient, when you do umbilical vein catheterization, then there can be a thrombus formation, and that can result in extrahepatic portal vein obstruction. I mean, the thrombus that is developing due to the trauma caused by the catheterization can progress to the portal vein and occlude the portal vein. So extrahepatic PVO stands for portal vein obstruction, happens to be one of the leading causes why the person would be having development of bleeding varices. Then is treatment of choice for bleeding esophageal varices. Though I have discussed this separately in the liver section, but the treatment of choice would be answered as endoscopic variceal ligation. See, drug of choice is something where we can fight over terlipressin versus octreotide infusion. But if he says treatment of choice, then it is endoscopic variceal ligation. And if he says how do you prevent the bleeding from esophageal varices, the answer is again endoscopic variceal ligation. The only problem is patient may not be getting that procedure done. So I can start him on a non-selective beta blocker like nadolol or propranolol to decrease the pressure in the portal vein, and thereby decreasing the chances of rupture of these esophageal varices. Then is Mallory-Weiss syndrome. This is a non-life-threatening condition. The source of bleeding in this case is also the left gastric artery. So when you read the word artery, the impression that comes in mind is that it is a life-threatening condition. But as I said, Mallory-Weiss syndrome is a submucosal tear. The reason for this submucosal tear is the retching that is occurring in this patient. Like this is alcoholic, he did binge drinking, or he can give an example of a lady. She's in the first trimester of pregnancy and she's having hyperemesis gravidarum because of like she has just consumed a bit of water because she was very thirsty, because she's saying that even if I'm drinking water, I'm puking. So I just drank a bit of it. And after that, when I vomited, there was so much of retching that there was frank blood present. That's because of the submucosal tear that is occurring, and the retching associated will contribute to tear where on the gastric side of the gastroesophageal junction. So that's the site to be remembered. The source is left gastric artery, and most of the time in these patients, if there is no active bleeding, like it will be a single episode, then the patient will be fine, then no endoscopic therapy. Yeah, if it's an ongoing bleed, if it's an active bleeding, ongoing bleeding, recurrence of bleeding, like he vomited, I was planning to discharge him and then he again had a similar kind of an episode, and it's an ongoing bleed, then we will have to fix it by using hemostatic clips. But otherwise, most of the time, nothing doing. I mean, majority of cases would be having no active intervention to be done. We can keep them under observation with the use of antiemetics and a regular soft diet to be administered. As such, I can say among all the conditions that I've said till now, this would be one where I can say that the prognosis will be relatively good as compared to others where the prognosis is guarded. In Mallory-Weiss, as I said, it could be like mucosal lacerations that have occurred, and they contribute to the extensive bleed that has occurred. So initially, like by seeing that blood, because little bit of blood in the wash basin also may look very, like I said, extensive. By extensive, I don't mean like it's like liters of blood. In this condition, it's like a blood coming from branches of the left gastric artery. So the blood in the wash basin might look like extensive, and this might cause vasovagal syncope in the patient or in the relative also, and seeing that splashing of blood everywhere. But overall, when you check out the total volume of blood, it is much more limited as compared to the other conditions that I was discussing. Now is a related aspect which has been asked in the exam. That is Boyer-Haave syndrome. See, Boyer-Haave syndrome is where there would be forceful vomiting, and then subsequently in this person there would be esophageal perforation. So Boyer-Haave syndrome, we have presence of macular striate. In macular striate, the guy would be vomiting, then he'll be having chest pain. The reason for that chest pain would be that if the esophagus will burst, it would result in development of chemical mediastinitis. I mean, whatever he had consumed, along with that there would be saliva in the esophagus, so the secretions in the esophagus. So I can say that chemical mediastinitis will explain the development of chest pain, and because there is a Boyer-Haave syndrome contributing to esophageal perforation, the air of the esophagus is going to escape into the mediastinum, and then is going to come in the tissues of the chest wall as well. Like especially if I keep my fingers on the suprasternal notch of this particular patient, then I might be able to feel crepitus under the skin, and that crepitus under the skin is the air that is dissected from the esophagus into the soft tissues of the chest wall. That's why the finding here is subcutaneous emphysema. In contrast, there's another condition where Borchardt striate has been asked, which is called as stomach volvulus. Initially, the question will start with patient having epigastric pain and having extensive retching. But then in this individual, you will notice that he's having extensive retching, but nothing is coming out because the stomach is folded on its own axis. If the stomach will fold on its own axis, we call it stomach volvulus, and that is why the NG tube in this patient will not be passed. So this is the only time where you will read this statement, NG tube is not getting passed, and we call it Borchardt striate. Both of these are like two important medical emergencies which I've discussed separately, though the initial part of mine was GI bleeding, but because of the fact that the wordings of these patients, MCQs would also be similar, no, like epigastric pain is something that we will read with peptic ulcer disease also, but then you'll say patient is having retching minus vomiting, inability to pass NG tube. That's when he's not talking about any GI bleed, he's talking about Borchardt striate of stomach volvulus versus macular striate for Boyer-Haave syndrome. Now comes the aspect of Dolufa's lesion. This is an enlarged submucosal artery. The main point is blood vessels are supposed to be on the serosal side, but the chap is having a submucosal artery, and this will cause a punctuate erosion in a otherwise normal stomach mucosa. Usually, like he'll say, what is the commonest location of Duluth's lesion? Then your answer would be lesser curvature. Just like I said, gastric ulcer is on lesser curvature. Duluth's lesion is usually occurring within 6 centimeters of the lower esophageal sphincter. Within 6 centimeters of the LES, this lesion is present in the lesser curvature. Now, I mean, why are we supposed to know it? Is because otherwise hunting for it in the whole of the stomach is like looking for a needle in a haystack. So this is a diagnosis of exclusion. If other causes have been ruled out, then we'd go in for a Duluth's lesion. Now, this is a vascular malformation. It can even be present in the large bubble. It can be present in the rectum, colon, and even in the small bubble. And for management of this patient, endoscopic hemostatic clips can be used to take care of this punctuate erosion, which can result in bleeding in the patient. A related extra mile to be remembered here is called as Higgs syndrome. Higgs syndrome is having aortic stenosis. Because of the aortic stenosis, there is going to be a development of shearing stress on the RBCs, and the shearing stress would also be present on the multimers of von Willebrand factor. And therefore, once we are having this shearing stress present, therefore those large chains of von Willebrand factor are fragmented, and therefore there is a von Willebrand factor deficiency. And because of the deficiency of the von Willebrand factor, there is a development of an acquired von Willebrand disease, which can increase the chances of bleeding from the associative finding that is seen in this condition. That is a vascular ectasia, which is a vascular malformation in the colon that can cause bleeding. So Higgs syndrome is actually a triad. In the triad, I'll repeat the 3 findings once again. One we get is aortic stenosis. Along with aortic stenosis, because of the shear stress on those long chains of von Willebrand factor, which are fragmented into smaller ones, the von Willebrand factor is like deactivated or is not able to function. So it is going to be literally like a deficiency of von Willebrand factor, which causes von Willebrand disease. Because traditionally von Willebrand disease is like having a genetic basis, but today we are talking about not a congenital one, but an acquired von Willebrand disease. The word acquired because of association with valvular aortic stenosis. And because of this von Willebrand disease manifestation, chances of bleeding from the concomitant vascular ectasia in the colon that they have tends to increase. The subsequent causes to be remembered are like cancers that can be like GIST. For gastrointestinal stromal tumor, one term that I would like you to remember is that if it is a localized tumor, then do not answer imatinib. If it's a localized tumor, then what we'll go in for is a surgical resection. This tumor is the one that originates from the interstitial cell of Kegel. I think you are aware of this from surgery also. Interstitial cell of Kegel is the cell of origin, so that is why we tend to call it a stromal tumor. This is not an epithelial tumor. Unlike adenocarcinoma, it is a stromal tumor originating from the interstitial cell of Kegel. If it is a localized tumor, then it is surgical resection. But if it will spread, most of the time the spread would be occurring to the liver of the patient. So in those circumstances, if it has spread, that is where we will be going ahead and using tyrosine kinase inhibitors for these patients. TKI, one of the tyrosine kinase inhibitors that we can be using in this patient is like imatinib. Then comes in cause, which is again a vascular malformation. We call it GAVE, that is gastric antral vascular ectasia. And here, when we do a upper GI endoscopy, it will show a very peculiar finding that I'll be showing you in an image in a couple of minutes from now. But the theory part is coming up here, that is called as watermelon stomach. This itself was one liner MCQ. Watermelon stomach is a feature of gastric antral vascular ectasia. Then can be prolapse gastropathy. Prolapse gastropathy would mean that it is the esophagus that would be, the stomach will be prolapsing into the esophagus. The stomach part prolapses into the esophagus, and that's where the mucosa of this would slough off and can contribute to development of bleeding. And this prolapse gastropathy should not be mixed with another disorder, which is a complication of portal hypertension, which is called as portal gastropathy. So there are two things that are very closely matching, because both of them are saying the word gastropathy. Portal gastropathy, as the name suggests, would be a feature that would be seen in patients with portal hypertension, where you can be having bleeding from two areas. One is from the esophageal varices, and second from the congested mucosa of the stomach. The portal vein pressure is more, so there would be congestion in the veins of the stomach mucosa as well, from where the bleeding is occurring. That is called as portal gastropathy, whereas in part number 8, the word is prolapse gastropathy. Then can be aortoenteric fistula and hemobilia. If he says what is the leading cause of blood in the bile, which will be causing blood to exit out from the ampulla vater, then hemobilia is also an upper GI bleeding because it is proximal to the duodenojejunal flexure, and the leading cause of this is iatrogenic. So your answer would be most of the time this is because of I would say, laparoscopic cholecystectomy that was done, but the surgeon who was doing this was a rookie in a sense that he did not achieve adequate hemostasis. And if adequate hemostasis is not achieved, then there can be development of blood in the bile following a laparoscopic cholecystectomy. So it is most of the time iatrogenic, and therefore because it becomes easier for you to solve, so a lot of these MCQs will say the word trauma. So final interpretation is, what is the most common cause of development of hemobilia? It is trauma, and by trauma I do not mean like a road traffic accident. It's an iatrogenic trauma at the hands of a surgeon who was performing laparoscopic cholecystectomy. He's not an expert at the job, he's a rookie, he's a new guy to the job. There was inadequate hemostasis, and that is causing development of blood in the bile. Then I will teach you regarding pseudo hemobilia. Pseudo hemobilia would mean that this time the blood is coming from the pancreatic duct. The blood is coming from the pancreatic duct, it will open into the ampulla vater, and therefore the blood will come in the second part of duodenum. So we are going to still classify it as upper GI bleeding, and the technical term for this blood that comes from the pancreatic duct is called as hemosuccus pancreaticus. Hemosuccus pancreaticus is bleeding from the pancreatic duct into the duodenum via the ampulla vater, and this occurs due to rupture or pseudoaneurysm of the peripancreatic vessels. And the reason for why are we having this pseudoaneurysm can be as something like acute pancreatitis. Pancreatitis, the leakage of enzymes can cause damage to the blood vessels. It can cause a pseudoaneurysm formation that can then rupture into the pancreatic duct, and the blood loss would be causing, the blood would be then traveling via the pancreatic duct into the second part of the duodenum via the ampulla vater. What you can see at the moment is the watermelon stomach. These markings are like the markings that we see on a watermelon, and that's a feature of gastric antral vascular ectasia. Now we will focus on small intestinal sources of GI bleeding. The causes of these would be vascular ectasia, that could be Dieulefeu's lesion. As I told you, Dieulefeu's lesion is like an aberrant submucosal artery, but then at the same time, this blood vessel is not only present in the stomach, but can be present in the small bowel like in duodenum, jejunum as well. Then can be malignancy like adenocarcinoma that can cause bleeding. Then can be NSAIDs. NSAIDs not only cause, like COX-1 inhibitors, not only cause bleeding from the stomach, but can cause involvement of the small bowel. And then is Meckel's diverticulum. This is usually an important cause from pediatric perspective. And usually the question that comes on Meckel's diverticulum would be two of them. Either he will say what is the scan that is used in this case. So your answer would be given as technetium-99 and Pertechnet scan. And the second reason why this is usually asked is the rule of two that you read in surgery. So I'll not write that, I'll just say this verbally. The important components of rule of two would be like 2 inches in size, 2 feet from ileocecal junction, and then there would be 2 mucosas. And especially the 2 mucosas that I'm talking about are like either the stomach mucosa, so there would be acid production, or it could be the pancreatic mucosa that can result in alkali production. So like these are some of the components of rule of two. I'm not written all of them, but then this explains the fact that gastric mucosa in 2 feet from ileocecal junction is not normal. It will cause erosion, it will cause damage, and that is why bleeding will occur. And then even Crohn's disease. Crohn's disease is one where we read about those deep serpiginous ulcers. Like a serpent, like a snake, those deep ulcers are present. These serpiginous ulcers can then cause damage to blood vessels and can contribute. When the ulcers will go down, they can cause GI bleeding as well. So those are like small intestinal source of GI bleeding that I'm discussing. I did not write here ulcerative colitis because ulcerative colitis causes GI bleeding, but then that would be specifically in the colon, because ulcerative colitis is a pancolitis. It does not cause involvement of the small bowel, though in some cases of ulcerative colitis, some segment of the distal part of the ileum can be involved. That is what we call it backwash ileitis. Backwash ileitis means retrograde extension of the damage in ulcerative colitis to the terminal part of the ileum, and has been discussed in the section of inflammatory bowel disease. Now coming to the workup of these patients for small bowel GI bleeding, we'll be doing following investigations. That is a CT angiography followed by an angiography. The rationale behind doing this angiography is mainly to detect any vascular malformation which could be contributing to development of this bleed. Then is technetium labeled RBC scan would help me with the same, I would say, vascular malformations also, and at the same time with respect to Meckel's diverticulum. Wireless capsule endoscopy would help me identify patients who are having Crohn's disease where there can be stricture formation. If I don't have facility for that, then I can do a MR enterography or CT enterography also. So it is like a battery of tests that would be done to determine the source. And now we come to lower GI bleeding. If he says lower GI bleeding which is not requiring hospitalization, then answer is very easy. It would be internal hemorrhoids. For internal hemorrhoids, the source of bleeding is superior rectal vein. The investigational choice is proctoscopy, and in primary piles, we'll be able to see the veins at 3 o'clock, 7 o'clock, and at 11 o'clock position, so that you can read from surgery also with respect to the internal hemorrhoids. That is the internal hemorrhoids at 3 o'clock, 7 o'clock, and 11 o'clock position respectively. Another cause can be patient is having constipation, and there can be anal fissure. The most common location of anal fissure is midline posterior. Anal fissure will be causing lot of pain present. Patient will not be able to sit also. So in these patients, we might have to use topical nitroglycerin, or we might be using topical calcium channel blocker. We might be using lignocaine because we wanna relax the sphincter. That is why I initially mentioned regarding nitroglycerin and calcium channel blocker. And even local anesthetics would be beneficial in patients of anal fissure, which is a very painful condition. But in all of these conditions, there would be like no requirement of hospitalization. The difference that I can use to differentiate them clinically would be that there would be a spasm of the anal sphincter in anal fissure, but there is no spasm of the sphincter in internal hemorrhoids, though sometimes the two conditions can coexist as well. In internal hemorrhoids, it will always be a flash in the pan that after the person has defecated, suddenly there will be spurting of blood. Internal hemorrhoids, it will usually be presenting as like flash in the pan. What I mean is that after the patient has done defecation, then suddenly there would be spurting of blood. Whereas when it comes to anal fissure, you will notice that there would be streaking of the stool with blood. I mean, he will himself say that there was passage a very hard pellet of stool, and this hard pellet of stool was having streaking of the stool with blood because of the tear of the terminal part of the anal mucosa that is happening, and the usual location is midline posterior. But if he says that there is so much of blood loss that the BP of the patient is decreasing and there is a need for hospitalization, then the number one cause of lower J bleeding where there is like need for hospitalization should be answered as diverticulosis. Diverticulosis is an area of weakness where vasa recta penetrates into the bowel. Like this blood vessel that I've shown, I'll just highlight it a little more. I'm zooming into this diagram. You see, here what I'm showing here is this blood vessel is what I'm focusing upon is the marginal artery, and then it is having branches which are gonna go deep down into the descending colon of the patient. And what you can notice here is that there is this is a barium enema. The barium enema is also showing those outpouchings, and these outpouchings are primarily because of that this guy is a non-vegetarian person. He eats only non-veg, he eats only meat, no veggies like an Indian diet. And because of the constipation, because when you eat meat only, you eat steak only, there's constipation, and constipation can result in development of this diverticula that develop in the bowel wall. So many of them, so the appearance is also called as a sawtooth appearance. And the source of bleeding in this case would be basically the marginal artery. So what is diverticulosis? It is area of weakness where vasa recta, that's the blood vessels that are penetrating into the bowel. Those are vasa recta are going to be the branches of the marginal artery. Those are branches of the marginal artery. Then diverticulosis is more common on the left side of the intestine. If he says what is the most common site of diverticulosis, then your answer would be given as mainly the sigmoid colon, or the left side of the colon is the one which is usually involved. Why sigmoid colon? Because it is relatively narrow, but the chances of bleeding are more with respect to right-sided diverticula. I repeat that again. When it comes to diverticula, the most common site is left side, and mostly it is sigmoid colon because it is narrow. But the diverticula on the right hand side are relatively bigger. So chances of bleeding, if he says increased chances of bleeding in diverticulosis is seen in left side of the large intestine or the right side of the large intestine, their answer would be given as large right side of the large intestine, where like the bigger diverticula are present. The source of bleeding would remain uniform, that is branches of the marginal artery which are referred to as vasa recta, and most of the time it will be like a geriatric presentation. Most of the time he will be mentioning like a American citizen or like a European person. I mean, that is mainly to describe the food habits of these people, that most of the time it is like these people are eating only steak or meat with limited amount of veggies being consumed. So they have been suffering from constipation from a very long time. But today when this patient went to the bathroom, there was extensive amount of blood loss. It was abrupt onset, painless hematochezia, or sometimes maroon colored stool could be present. And the amount of blood loss can be severe enough to cause dizziness and even syncopal episodes. Here in this image, you can see those blind openings present. These blind openings are what I'm trying to say is the mouth of the diverticula. These are the mouth of the diverticula that we can pick up with respect to diverticulosis. And then what would be the interventions that would be done? So in case we are able to prep the patient with polyethylene glycol, because if I do colonoscopy without preparation, there is only fecal matter now. So if the patient is hemodynamically stable and I can do preparation with polyethylene glycol, then it is okay colonoscopy. But if there is like a hypotension, there is unrecordable BP, hemodynamic instability, then I will be doing angiography in this patient. So this is an important point to be remembered, that both can be answers in the question of diverticulosis depending on the blood pressure value. If he says that patient became unconscious, hemodynamic instability occurred, then it is first CT angiography followed by conventional angiography. But if the patient is having hemodynamic stability, then colonoscopy. Majority of cases will resolve on their own, but ongoing bleed will require angiographic embolization. So this itself is a question, that in a person who's having diverticulosis with ongoing GI bleeding, which is causing persistently low blood pressure, what is the main intervention to be done? Then it is angiographic embolization. I also mentioned or showed before you this sawtooth appearance, as you can see with respect to the diverticula that are present in the left side of the colon of this patient. So sawtooth appearance in barium enema is a feature of the topic that has just been discussed, that is diverticulosis. However, there's a related MCQ which I think you remember from both the cardiology as well as from the neurology perspective, that sawtooth appearance on EEG is a feature that is seen in REM phase of sleep. And then when it comes to sawtooth appearance on ECG, that's a feature that's very classical. I mean, for that, I don't think so I have to prompt you. The answer would be given as atrial flutter. Then is inflammatory bowel disease that can again result in development of bleeding that can be extensive enough to cause hospitalization. And one of the classifications that I've discussed in the inflammatory bowel disease section for the extent of the disease is called as Montreal classification. This classification helps to determine two things, extent and severity. But first, it is the extent of inflammation, that if the inflammation is involving only the rectum, that would be written as like E1. If it goes from rectum up to the splenic flexure, E2. If it goes beyond the splenic flexure, we call it E3. So more extensive the disease, more will be the chances of bleeding. No, I mean, Montreal classification, another one that is added, is mainly to determine the extent of the involvement of the bowel and the severity of involvement as well. That is like the function of doing this classification. The test that we can do in this patient would be like a wireless capsule endoscopy or MRI enterography, specifically for Crohn's disease. This would be the approach that would be answered. But if he specifically talks regarding ulcerative colitis, then for ulcerative colitis, I can straight away be doing a sigmoidoscopy or a colonoscopy and evaluate, because ulcerative colitis is pancolitis only. Then if I've ruled out diverticulosis and IBD, it can be cancer. By cancer, I mean it could be cancer of the cecum or cancer of the rectum. You will notice that cancer of the cecum usually has higher chances of bleeding, and most of the time the stool occult blood test will turn out to be positive. Along with this, he will mention the word progressive anemia in this patient to the level that the hemoglobin at the time of detection could become like 5 grams, 7 grams. Carcinoma rectum is gonna mainly present with obstructive symptoms. The cancer of the right side of the colon tends to present more with bleeding, and the cancer of the left side of the colon tends to present mainly with obstructive symptoms. If these causes have been ruled out, then we need to consider regarding ischemic colitis. Ischemic colitis can be seen with respect to illicit drugs like amphetamines. I mean, abuse of amphetamines can contribute to spike in blood pressure, even brain hemorrhage. But then today we're talking about damage to the gut, the sloughing of the gut mucosa will occur. We call it ischemic colitis. People who are trying to do too much of exercise, chronic constipation are risk factors, and the X-ray abdomen here will show a very classical finding that is called as a thumb printing appearance. Not traditionally we talk about like thumb sign on X-ray lateral view for epiglottitis, but today I'm talking about a thumbprint pattern on an X-ray abdomen, which is itself a question, and the main test for confirming would be colonoscopy. Then we can have NSAIDs that can cause damage to small bowel, that it can cause damage to stomach, it can cause colitis, they can be rectal varices, and then comes a vascular malformation that should be remembered, that is angiodysplasia of the colon. In these patients, most of the time, the colonoscopy will be normal, not once, but multiple times. I mean, like this guy is having blood in the stool. So colonoscopy was done and it was normal. When I say multiple times colonoscopy was done and every time it was normal, that means common causes have been ruled out. No, like there's no diverticulosis, no IBD, no malignancy occurring in this guy, no colitis component present. So if colonoscopy is normal multiple times, Then what is the next investigation to be done? That would be a CT angiography followed by an angiography to form or identify a vascular malformation. So specifically, if he says what is the leading vascular cause of lower GI bleeding, the vascular cause would be answered as angiodysplasia of the colon. If it does not say anything, then he says what is the number one cause? It is piles. But if he specifies that the blood loss is contributing to hypotension and hospitalization, then it cannot be piles. Then answer would be given as diverticulosis. I have already explained this to you that if it's an acute lower GI bleeding with crashing of blood pressure, then the initial investigation that must be done in the person is upper GI endoscopy. If upper GI endoscopy report is negative, then in those circumstances, the next investigation to be done will depend upon whether the person is BP. I mean, if it is like unable to prep, then we'll do angiography. But if we can ensure at least some decent blood pressure value, then colonoscopy can be done. But for that, we have to give like PEG to the patient, that is polyethylene glycol. And if systolic BP is normal in acute lower GI bleeding, then it is okay. Younger patients, he says sigmoidoscopy. Older patients, more chances of cancer, going for colonoscopy. So for right hand side, I don't think so there would be a challenge, because if BP is normal, we just need to scan the colon using sigmoidoscopy and colonoscopy. But for acute lower GI bleeding, if BP is crashing, it is upper GI endoscopy to be done. Usually it will be a undiagnosed case of peptic ulcer disease, which has resulted in this extensive amount of bleed. If the report is negative, then the decision making for colonoscopy versus angiography is based on the subsequent blood pressure values of the patient. I mean, if we can prep the patient, then okay, it's a colonoscopy. Otherwise, if I do colonoscopy without prepping, all I will meet is with the fecal matter. Let's attempt a question now. He says, alcoholic presents to the emergency department with severe abdominal pain and feeling lightheaded. Examination shows a non-cooperative patient with rebound tenderness along with low hemoglobin and increased TLC and deranged KFT. Also, vowel sounds are reduced. Considering that there is rebound tenderness in an alcoholic, I could be thinking in terms of possibility of a perforation of the intestine. There could be a viscous perforation occurring. The answer to this question is not option number A. Viscous bleeding is not, it's a viscous perforation actually. If you look at option number B, Mallory-Weiss syndrome, that looks like the answer to this question only if he mentioned regarding any vomiting, but there is no mention of any vomiting of blood. No, Mallory-Weiss presentation is hematemesis. There is no vomiting of blood given in this question. I'm left between bowel perforation and then portal hypertension, and portal hypertension will also be having vomiting of blood. So initially I thought that because he's talking about alcoholic, it could be a question of alcoholic cirrhosis, so there was bound to be portal hypertension contributing to hematemesis. But here the answer surprisingly is bowel perforation. Not surprisingly, we just have to use exclusion, and the findings which are the core ones are rebound tenderness and bowel sounds being less. Now, why there is a anemia component that can be seen in this patient? Well, the plausible explanations are anyway Indian patients are having less hemoglobin. Another explanation is alcoholics are having anemia. This anemia could even be a macrocytic anemia, which can be seen with alcohol intake. So these are the details for this topic, guys. Thank you so much for your patience and hearing me out, and keep hammering, keep the pressure on, and continue doing these topics on a loop so that you're just able to get the things over. And like the first read is going to take a bit of time, but once you are able to complete all these topics now, then you start getting a bird's eye view of the entire domain. Then things will become relatively much more simpler for you. So thanks for your patience again.